Welcome. This video today is going to discuss in-community services, advancing your reach and impact. My name is Carla Licio. I'm the Director of Healthcare Reform Consultation at the National Center on Addiction and Substance Abuse, better known as CASA MCTAC. And with me today is
Pat Lincourt. I am the Director of Practice Innovation and Care Management at OASAS.
So let's talk a little bit about in-community services. I think what would be a really good idea would be first for us to set this in the context of healthcare reform, because in-community services really is an opportunity for OASAS providers to utilize this new creative service to advance their delivery system. So healthcare reform speaks to the need for building capacity to integrate care with other healthcare providers. This will enhance your ability to negotiate with health plans and new provider networks. Plans and networked providers will expect evidence that you can engage patients and demonstrate good outcomes. And so you as a provider will need a lot more flexibility and opportunities to connect with those other provider systems to make these imperatives happen.
So I think that the healthcare reform in general offers opportunity for SUD providers. This opportunity came with the managed care carve-in and the demonstration that was approved by CMS. And it will allow for our SUD providers to go anywhere in the community really to offer services. And that's the beauty, I think, of the offsite services or the in the community services, is that for providers, often they've been stuck to the four walls of the clinic for doing clinic service. And this will allow them to do some very innovative things. Some of the things that have frustrated providers is losing contact with patients and not being able to bring them back to service. Sometimes there's been difficulty with linkages back to outpatient care. This will allow the clinic to go to where patients often show up in a detox or an inpatient program, send a peer or a clinical staff person to do a service. And Ileana Meltzer is going to talk later about billing for that, but this allows for all of those things to happen. It really serves that imperative that you're talking about in terms of integration, being able to really work with other partners.
Right, it's really a creative opportunity. I think that one of the things that you were addressing in that moment there is the need to improve access, engagement, and continuity of care. And so many times providers have struggled with how to successfully provide access to clients, better engage them, and make sure they have a way of connecting with them when they're at risk of losing them to care.
Yes, I mean the barrier has really always been you can make a phone call or do an outreach in that way, but to actually go where the clients are in the community has been a real barrier to being able to keep that continuity. And so you know it's a thread that will help tie together, I think, some of the community providers that where patients are showing up perhaps at an Article 28 clinic and not making a connection back to the clinic, even when there's some motivation to do that, but just something that's getting in the way.
I'm glad you used the word thread, because that was a beautiful image that actually Ileana Meltzer I heard use on a call. And I had wanted to, in some way, create that visual for providers, in which in-community services are a way of knitting together a community of providers, that these are the services that we can use to make sure that the clients get from one service to another. It's really knitting together a community. And I love that image.
And I think, just to be specific about the types of service, any service that is billable in your clinic now, it would be able to be provided and billed for now, anywhere outside of the four walls where you can find a safe and comfortable and private place to meet with and provide that service to a client of your clinic. The spirit of this is that you're still operating as a clinic and providing the services that you would as a clinic, but you can now do it in a more rehabilitative way. And as you're saying, in the community to help create that thread for different services to bring that person a more cohesive treatment.
So would this be a way that a patient who's being referred from one service system to another could be insured to get to the next service?
One of the things we think is that this will improve providers' ability to do the warm handoffs that we've been talking about, but there's been a lot of barriers to actually implementing when you have a staff person who belongs to one discrete service and another who belongs to another. It's difficult to actually do that warm handoff. In this case, you could have a peer or a clinical staff person at a detox or an inpatient program, maybe a day a week or for a few hours. And that person's job could be to welcome and to engage people either initially into service or back into service.
This is great. So let's talk a bit about summarizing some of the opportunities that we've just been highlighting. So some of the opportunities include integration, maximizing the strategic use of peer services, which there's a way when you improve access, you improve engagement, you improve continuity of care, that can lead to an expanded census, increased revenue, and expanded reach of your service. I think about all of the people who need treatment that don't ever get there. For those providers who don't have primary care on site, this is a new flexibility to creatively partner with primary care. And ultimately, this can enhance your value.
Yep. I mean, one of the examples that for the primary care is sometimes there are primary care physicians who don't feel comfortable doing addiction medication because they don't have the support necessarily.
Right.
And it's, this would give an opportunity for a counselor to work with that primary care setting to actually be on site to offer some supportive services and, ultimately link that client back to the clinic perhaps, or even provide some services on site at the primary care setting. And it also offers an opportunity to build a peer program or a peer capability that has been difficult to implement when peers were tied directly to the clinic. So there is a lot of opportunity in this, and there's a lot to think about too in terms of how to actually implement. It's not I think that for programs who are watching this and are interested in the community services, some of the things to think about are that this is complex, that you have to think about the utilization of staff, where how you're going to generate revenue, how you're going to physically you get your documentation from the site, so there's still all of the responsibilities to the regulations are there. So while there is tremendous opportunity in this, it also needs to be thoughtfully implemented.
So Pat, if we were to think of some examples, you just referenced an example in which an OASIS provider can provide clinic services on site in a primary care setting. Could that happen in a mental health clinic setting as well?
To the degree that the mental health setting is welcoming of that, yes. There is not a restriction really on the places from the OASIS Article 32 point of view about where services could happen, and so there's lots of opportunity to partner with other providers where on-site services could happen at a clinic, at a drug court, at a primary care program. in the community where patients go. So if there was a recreation center, for example, that would be a place where a counselor might do some engagement or re-engagement of patients.
And suppose I am a provider in a clinic and I know that I lose a lot of referrals in that transition from one level of care to another. Might that be an opportunity to use a peer to do some in-reach work?
I mean, I think a lot of providers are very aware, of how difficult it is for somebody to actually show up at a clinic.
Yeah.
And so a lot of times people can do that once or twice, but they lose their nerve, they get scared, and it's easier in a lot of ways. And so the clinic could utilize a peer to go out and re-engage that person who has been lost to contact. So there's a lot of opportunity in that.
So through integration, in particular with a primary care setting, it seems as if there's also an opportunity to, in some cases, to partner with the staff at that setting to together provide a service that alone the OASIS provider may not have the resources to provide. So that in community services may be an opportunity to expand the reach of your resources. And in particular, I'm thinking about the possibility of partnering with a primary care setting in which there may be an MD on site that would be willing to do some of the medication piece of medication-assisted treatment while the clinic provides the counseling therapeutic piece.
Yeah, I think it's integration models are obviously something that we're striving for, and
right.
But it's difficult because the barriers. People are working in their own setting and with their own kind of focus. But I think that everybody is recognizing the need to be able to offer services within a primary care setting, and primary care services also within behavioral health and SUD settings. So there is opportunity here, and we're interested to see what kind of models may be able to be built on this. And being able to provide services in the community outside of the clinic does offer a flexibility that we haven't had before for developing some of those models, and for offering primary care settings some of the expertise of a clinic, within their own setting. So yes, this is something that we think will develop over time.
That's an excellent point that I want to highlight, which is, as an OASIS provider, it's important to remember that the primary care settings and other settings are seeing our clients, our patients, and that they're struggling with, how can I best help this person? And an OASIS provider can step in and provide some answers there.
Absolutely. It's the SUD expertise is often something that's very valuable to a primary care setting. But they have lots of things that are very valuable, and lots of things that they have to pay attention to. And so, when you have an opportunity to reach in and to offer that, I think that it can be very valuable and create an opportunity for being able to help people to engage in treatment that otherwise wouldn't have that opportunity.
Yeah, this is great. I want to switch now, Pat, to peer services. We referenced peers earlier, and this is another initiative that in community services can really give a boost to.
The peers have been billable in OASIS settings since the implementation of APGs. It's been difficult to get that off the ground. First, because the rate was recently adjusted. It originally probably wasn't sustainable. At this point, we think that the rate is is enough to sustain a peer program, but having peers only be able to operate within a clinic, it doesn't do justice to the opportunity of peers to being able to do the outreach and see people in the community where where they need to make the recovery connections. And so this, the in-community services really offer an opportunity for a program to begin to really build a peer capability and to capitalize on the value of peers by being able to do some of that in-reach for warm handoffs, being able to engage new patients in treatment, and re-engaging those that may be lost to care.
Yeah, peers really have some unique skills and offerings for the Oasis provider services. So we can talk about some potential peer specialties, but we want to remind everyone who's watching this video that although Pat and I are talking about examples and potential uses of this service, there really is creativity and that there's encouragement to really think through how these services can best be utilized within your clinic. So I think we've referenced a few uses of peers. So to secure linkages, referrals from other levels of care. Those referrals can be accompanied by a peer from the moment they leave that service to walk directly to your clinic. Community outreach and engagement is a terrific use of peers. Someone may have missed a clinic appointment. You can follow up with peer visits in the community to re-engage. Providing linkages to a lot of the critical social rehabilitation services that are out there that are important to everyone's recovery. But again, these are just a few ways that you can think about using peers and how to market your ability to use peers to your best advantage.
I think that having the peers be an integral part of what you offer in your service mix will be something that payers are going to be interested in as we move into the future, because they do bring such value to the clinical part of what a program can offer.
You know, as we're talking, it's really clear to me that this is a complex initiative and that it requires providers to really sit down and think it through. It's not to utilize this to its maximum advantage. Take some time to think through all the details. Go ahead.
Yeah, well, I think that's very true, and I think that while we want to encourage people to take a look at the opportunity here to go back after viewing this video or webinar and to talk with their own patients, perhaps with their own staff, their own board of directors, to start thinking about things like where are their clients getting primary care or mental health, and are there referral sources where there's a potential to make some linkage to have clients make a better connection to your services. But you also don't want to make too many moves too quickly, because you also need to balance, the opportunity to offer these services with the need to also make it sustainable from a fiscal point of view. So thinking this through is something that we would highly recommend. Having a real plan, maybe even using a more formal kind of change process within your staff, and having some champions or an actual formal change team would be something that could really help to think this through.
And at the end of this video, I'm going to talk very briefly about Casa McTack's interest in developing learning communities or learning modules around this type of service. So more to come on getting ready to implement.
Great.
Included in implementation and preparation, we want to emphasize that there's a lot of details to be attended to, and you identified just a few throughout our talk today. So think about documentation. You're sending staff to deliver services somewhere in the community at another site. Where is the documentation being done? How is it being done? Who has access to that documentation?
And one of the, I mean, OASAS has issued the guidance, and we'll provide a link to that here too for people who haven't seen that. Documentation, the requirements are exactly the same as they would be for clinic, and it has to be secured in the same way that it would in a clinic. HIPAA and CFR 42 apply equally to the information and how it's gathered and who has access to it. And it has to be stored in a way that, that meets with all the regulations and requirements.
In preparing for this, all of this requires collecting some data. So to know how to implement this, you need to have some answers around how many referrals are lost to care. How many referrals never make it to an assessment? How many never make it from assessment to a first appointment? How many referrals do you have from a particular provider? So think about what is it that you want to know, how will you know it, and how will you report that out? Because remember also, data is going to be necessary after you implement these services to determine, how's it going? Is this working? Does it need a tweak?
I think training too, thinking through, are there differences in evidence-based practices when you're delivering things in a different way? What's the culture of the setting that you're sending staff to, and how does that fit with your own culture? And how will you help that staff to be able to, really feel a part of of the team? And then, thinking through some integration strategies, and there's great resources around that. I know MCAC has helped people think through that with some terrific resources as well.
Right. Supervision is another issue. So you have staff that are not right in your clinic. How will you supervise them? If you're introducing peers for the first time, there may be some supervision things to think about.
And the billing workflow. So, it's challenging enough sometimes even within the clinic to get that workflow down. And now you also have to make sure that you're getting all of the information that you need to be able to bill from that staff person to your billing folks.
Exactly.
So that needs to be thought through as well.
Another thing to think through is safety protocols and policies and procedures. It may be less relevant for someone who is on a site, but if you're sending peers into the community, you want to have a way to think through, how will you know where they are? How will they communicate with the clinic and their supervisor about where they are and where they're going? What sort of check-ins do you want to have at the end of the day? I know that some mobile programs have a buddy system in which at the end of the day, the buddies contact each other and say, I'm home. So there may be a lot to think through there.
Absolutely.
I think at this point we want to head into a little bit of a discussion about billing guidance. And so we're going to bring Ileana Meltzer into our next phase here.
Great.
Pat, this has been terrific.
Thank you very much. I appreciate the opportunity. We're excited about this. Thank you, Carla.
So at this point, we want to address our attention towards billing. And to cover that today, we have Ileana Meltzer.
Hi, Ileana Meltzer from OASAS with the Division of Practice Innovation and Care Management. And thank you, Carla. One of the things we're really excited about is the opportunity to provide services within the community. However, a question we naturally frequently get from the field is, how does billing work? And the primary point to remember is that billing for services in the community is tied to the integration of the SUD and mental health services into the Medicaid Managed Care benefit package. So the first step to remember is that providers will be having contracts with the Medicaid Managed Care companies as they begin to start to integrate into the managed care networks. From that contract, that's what provides the platform for the providers to be able to submit the claims to the Medicaid Managed Care company. The ability to do that is tracked to the implementation dates of the Medicaid Managed Care implementation in New York State. So in New York City, that's October 1 of 2015, and in the rest of state, July 1 of 2016. So after that July 1 date, throughout New York State, all programs that have a contract with the Medicaid Managed Care Company would be able to start to really think about how they want to integrate services in the community. What I'd like to emphasize is that the Medicaid fee-for-service billing component of it will be very limited. The only time a program would be submitting a claim to Medicaid fee-for-service is once the state does get federal approval to do Medicaid fee-for-service claiming, and if that particular individual is not in fact enrolled in a plan. So the big takeaway point is one of the things that Pat and Carla were talking about earlier is the different groups that are coming together to knit together the community of providers. So the takeaway point is to remember that the plan themselves is going to be your partner as you think about how to integrate services within the community into your overall program operations. So as you start to do the type of work that Pat and Carla were talking about how do you want to set up your program structure to support services in the community, consider having conversations with your plan as your partner to further enhance the opportunities for the service recipients and the plan enrollees. From a technical perspective, there's two primary things related to claims submission. The first is to review the online clinical and billing guidance manual that is specific to delivering services in the community. Additionally, the program may also want to refresh their understanding about how to submit to the claims to the plan. In the main, both the coding and the reimbursement is the same regardless of where the service is delivered. So services that are delivered in the clinic or services that are delivered in the community, you'd be using the same claiming construction. And later on, I believe we'll be doing a webinar which will also allow providers to submit additional questions should they review the material and have finer detail that they might want to track down.
Right.
So the big thing to remember is that the reimbursement is primarily flowing through contracts with the plans. The plans are your partner as you consider to think about how to deliver services in the community. Thought the Pier was a great example of that. Plans are certainly interested in doing that.
Very.
Yes, very much so. And that statewide, the opportunity to do services in the community and run it through your plans will be available July 1st, 2016, and it's already operational within New York City. So that's really all I have.
Outstanding. Thank you so much,
Thank
Ileana.
you. Okay.
Let's talk about next steps. First, Casa MCTAC will be offering a short-term either learning community or some type of learning module focused on implementation issues. There will be more information on that to come. For you now, following this video, consider starting on analysis. Think about resources, the budget, potential partners, and other resources that you will need related to implementing in community services. And finally, our final message today is to think big and start small. I want to take this time to thank you for watching the video. I also want to thank Ileana Meltzer and Pat Lindcourt from OASIS for their participation and assistance in this video. Thank you again.